Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor in the UCSF School of Nursing. In this module, we're going to talk about treatment-resistant depression, an all too common condition for many of our patients who suffer with mood disorders. In this module, we're going to talk about how to think about treatment-resistant depression, how to define it, and to understand some of the challenges that come with treating depression, as depression is often a very heterogeneous disease without a clear underpinning of psychopathology or of pathophysiology, I should say. And we're going to talk about using a research-based algorithm to make our treatment decisions as we go forward. We'll also use a study called STAR-D as a way of plotting out our next steps. So what is treatment-resistant depression? Part of the challenge is that we don't have an agreed upon definition. Many research studies who are focusing on people who've had treatment-resistant depression have set an arbitrary limit of that one has to have failed at least 2 trials of an evidence-based antidepressant. And those trials need to be with drugs that have clear evidence or indication as antidepressants dosed at typically effective doses for at least 6 weeks. And that's a common duration of most antidepressant trials. So things that are shorter than that are usually not considered failed trials. But there's really no definition in the DSM. It's not a DSM diagnosis, but this is a commonly encountered clinical problem. And we want to be careful with our language when we're talking to patients about antidepressant trials because, as you can imagine, people with depression are often quite sensitive to negative language and feeling like they have failed as it is. And we certainly don't want to make them feel like they failed the antidepressant because in reality, what happened is the antidepressant failed to get them better. And that unfortunately, treatment-resistant depression is quite common, and that about a third of patients who develop depression will eventually develop treatment-resistant depression. So this really underscores the need for us to develop effective treatments for people that don't respond to the first-line agents. Now, this could be a whole conversation in and of itself, but many of you are probably unaware that before DSM-4, there were actually subtypes of depression. There was something known as melancholic depression, which I'll talk about a case of that in a later module, atypical depression, psychotic depression, which we've talked about a little bit, and kind of an anxious or what was historically called a neurotic depression. And I bring these up here not to get into the granular details of each of these, but really to point out that when we move forward with our DSM taxonomy, we attempted to put all these different types of depression into one large bucket. And the problem when you lump things together is that you lose nuance. And if you talk to anybody who's been in practice for a while, perhaps you can attest to this from your own practice, is that you know that depression is a protean condition. It presents in many different ways. Some people are very anxious and ruminative. Other people hardly have a thought in their head, but they can't seem to be able to get anything done. And so those are very different orientations to depression. And so it may be that what we call depression is really 10 or maybe even more different disease states that have different underlying etiologies. One thing we want to be sure, go back here. One thing we want to be sure when we're looking at depression is that we have the correct diagnosis. And we want to make sure that before we consider that our treatments have failed, that they're actually taking them. So many times what we call treatment resistance is actually more treatment non-adherence, and that they're actually not taking the medication, and therefore we don't really know if it would work or not. Or we are giving them an inadequate dose or an inadequate duration of treatment. More commonly, what we actually have is the wrong diagnosis. And what we've diagnosed as major depressive disorder, typically recurrent, is usually bipolar disorder or complex trauma or personality disorder or substance abuse that we don't know about. So it's really important that we screen for these possible other diagnoses before we assume that we have treatment-resistant depression on our hands. And we also need to ask ourselves the question of, is there anything that would be lost for the patient if they got better? And I know that sounds like a strange question, and that can be misinterpreted to make it sound like the patient is willfully manipulating the diagnosis. And I don't want to insinuate that, but I want to be clear here that for some people, if they've been depressed their entire adult life, their identity is often wrapped up in having depression. And if their depression were to get better, they would be left in a state where they're not quite sure who they are or what to do with themselves. So we need to think about that as well. Now, when we talk about depression, I think about this old Indian parable of the old man and the elephant, the blind man and the elephant, rather. And in this, you may be familiar with it, the blind men are feeling different parts of the elephant. And they are quite convinced that the gentleman who's touching the tusks is convinced he's feeling a spear. The person holding the tail is convinced he's holding a rope. And the person who's touching the flank is convinced that it's a wall. Well, you know what? Their perceptions are all correct, but they're all describing the same thing. And it feels like we often do this in psychiatry with depression, depending on the way we've been trained. You know, if you are more of a biologically oriented person, you might think about things like systemic inflammation or other medical conditions. If you're more psychodynamically oriented, you might think about reenactment of childhood relationships or a personality disorder. You get the point. That oftentimes we clinicians are these proverbial blind men describing the same thing from our own different perspectives. And we're not necessarily it's not necessarily there's only one answer. Oftentimes there's multiple answers, which is sometimes why you need to come at this with different approaches. And when we look at all the different causes of depression, we see here that that there are probably many. Of course, many people come into life loaded with genetic predisposition towards depression, or have difficult childhoods, which may lead to epigenetic changes in their own biological expression. And there's been multiple pathways that have been examined for possible explanation of depression. You know, glutamate dysfunction, inflammation, increased HPA axis activity, decreases in monoamines such as serotonin, etc. And that these may have a final common pathway of causing premature cell death, decreased synaptic plasticity, ultimately resulting in what we know as a phenotype of depression. Now, so that's the bad news, is it's a complicated illness. The good news is, though, is that we have a lot of different potential opportunities for intervention. And I won't belabor all the different points here, but you can start to see where we might be able to shift things, everywhere from primary prevention and genetic counseling, all the way up to changing network activity, increasing synaptic plasticity, and ultimately, hopefully, shifting the expression of the depressive phenotype. Now, by this point, you're pretty familiar with the antidepressant classes. We've gone through the serotonin reuptake inhibitors, SNRIs, and I'm going to talk more about the tricyclics, the atypicals. You've already covered norepinephrine reuptake inhibitors in the form of Wellbutrin, but also touch on MAOIs. And in this talk and in the future talk on psychedelic-assisted therapies, I'll talk about the glutamate receptor antagonists. Now, I like to use STAR-D as a roadmap. Now, this was a large study done in the early 2000s. It was funded by the National Institutes of Mental Health. And that's important because most antidepressant studies are funded by the drug company who is producing the drug. And so there are some inherent biases in this. The NIMH said, let's try and study real patients in as much real world problems as possible. So we're not going to screen out people that necessarily have substance abuse problems, for example. We're going to do this in psychiatric and primary care settings, which is also representative of what real life practice looks like. And they really wanted to try and figure out what works for treatment-resistant depression. Now, everyone started out on citalopram. So this is a large study, 2,800 patients. And when you came in, everyone was given citalopram. And the way this was set up was that if you got better, you got out of the study. So the people given citalopram, about 25% of them went into remission. So that's great. Those folks exited the study. And of the remaining people, about half of them had a partial response, and then the remaining 25% had no response. So at this point, you could either be switched to either sertraline, which is Zoloft, venlafaxine, which is Effexor, or bupropion, which is Wellbutrin. And you can see the doses that were average. They're fairly common doses, 135 milligrams of sertraline, nearly 200 milligrams of venlafaxine, and almost 300 milligrams of bupropion. So pretty representative doses of those drugs. And you can see that a slightly smaller percentage of people went into remission on each of those arms. So those people got out of the study. Or if you didn't want to switch, you could augment. So the augmenting group remained on citalopram, but they were either had bupropion added or Buspar added. And again, you can see the doses that were used there, fairly common doses in clinical practice. And again, about 30% of those people got better. Neither group was superior to the other. And if you got better, you got out, okay? So now who's left? At this point, now we have 377 people left over. Okay, we're now at level 3. So these are people who are still not in remission or have only had a partial response. Because remember, we're always shooting for full remission whenever possible. So of those people, you either had a choice to either be switched at this point to a tricyclic called nortriptyline or Pamelor, or switch to an atypical antidepressant called mirtazapine or Remeron. Again, the doses are there. And what you're starting to notice here is that the proportion of people getting better with each successive stage is getting a little bit smaller. So now we only have about 20 and about 12% of people respectively remitting at this third level, and those people got out. Or you could stay on what you were taking and you could be augmented with either lithium at a dose of about 900 milligrams a day, or with Cytomel, T3, thyroid hormone, at a dose of about 45 milligrams a day. You can see that the T3 group did a little bit better than the lithium group, and that the T3 folks tolerated it a little better than the lithium group. But again, diminishing returns on each successive layer. So now for the poor folks who still were not well, and that leaves us 142 people. So we're now at level 4. And these folks were given the option of either going on to tranylcypromine, which is Parnate. This is an MAO inhibitor. And you can see only a paltry 7% of the remaining people went into remission at this point. Or you could be added, you could have this combination of mirtazapine plus venlafaxine together at fairly common doses, and about double the amount of people, but still only about 14% of people went into remission at this point. So unfortunately, what this means is that there were still a handful of people, I don't know exactly how many were left, but still probably close to about 100 people from the original 2,800, I believe it was, who were still suffering from depression even after 4 different trials. And unfortunately, we tend to see those folks in our clinical practice. Folks who are in primary care tend to see the people who get better or they get referred on. Those of us who are in specialty care tend to deal with these more refractory cases. So what are the downsides to STAR-D? Well, first of all, it's old now. It's over 14 years old. And it was before some common practices, which I'll discuss in later modules, but it was before atypical antipsychotic augmentation was common in depression. The SNRI that they used, venlafaxine, was I believe the only one that was on the market at that time, but it's a more difficult to tolerate drug than some of the other SNRIs such as duloxetine. So some of the people might have dropped out because of lack of tolerance. They did not use stimulants as an augmentation strategy. This sort of predates TMS, this predates ketamine or S-ketamine, and this is also before we started to investigate psilocybin as an antidepressant. And also the effects of therapy times the drug, or the additive effects of being in therapy in addition to taking the medication was not accounted for in STAR-D. So it certainly has its shortcomings, but it gives us a reasonable roadmap from which to go forward. So the good news about STAR-D is that a good portion of people, over 25% of people, got better with your first agent. That's great. And for those folks, they probably have a better course than the people who have to go through multiple trials in order to get better. And it also tells us that if you're methodical and you follow a sequential path, then you're likely to get better outcomes. And that's certainly been my experience in clinical practice. The bad news is that we know that with each step of treatment, your odds of remitting actually go down. And that's just the nature of the beast, unfortunately. It doesn't mean we should stop trying, but it does mean that when we've seen somebody who's had 20 different medications, the probability that the 21st one is going to be the magic bullet is pretty darn low. And it also tells us that clearly depression is probably multiple diseases that are heterogeneous in nature. As we go forward, I just want to make some caveats about off-label drug use. Now, we talked about this earlier, that when the FDA approves a drug, it approves it based on what's called a label. And this label contains the indication and the dose for the drug. Now, when you use that drug for something that is not on that label, or if you're using it at a higher or lower dose than what's on the label, this is called off-label use. And this is fine as long as it's a common practice within your specialty. Essentially, if 10 people who have the same training and experience that you have would stand up and say, yeah, I do the same thing all the time, then you're fine. You always want to document this, even if it's a common practice. So for example, trazodone, which you've probably all given somebody for sleep, does not have an FDA indication for insomnia. It is only listed as an antidepressant. So every time we give trazodone for sleep, that's an off-label use. Very common, just fine, but you want to document that you had a conversation with the patient. Normally, I have that conversation by saying, so when you Google this medication, trazodone, you're going to see that it's actually an old antidepressant, and there's nothing in there about sleep. But I want to reassure you, we do this all the time. It's quite safe. And it turns out that this medication didn't work very well for antidepressant purposes, but some clever person figured out that even very small doses make you sleepy without having a lot of side effects. So we mostly use it for sleep now. But I just want you to understand that. And then you can document that the patient gave informed consent. Now, a lot of people say at this point we should do pharmacokinetic testing. And I want to be clear about what something like GeneSight um, tells you. So you get these results back and they look like this little chart up in the corner. And this is kind of deceptive, because what they're testing for here is that they are looking at the speed of the enzymes which break down the drug. So if you are a rapid metabolizer, what that tells you is you're probably going to need a higher dose of that drug in order for it to even have a chance at being successful. If you're a slow metabolizer, you're going to get a lot of side effects even at normal doses. What this implies is that it tells you if the person will respond to the drug. And that's where I take issue with it, because that is a different question altogether. Now, for sure, if you dose somebody at normal doses and they're a rapid metabolizer, they may not benefit from a drug that could be dosed at a higher dose and they would tolerate it well. But the way this is laid out with these green, yellow, and red boxes, I really take issue with, because it's led a lot of clinicians to think, oh, the green drugs will work, the red drugs will not. And that's simply not true. All this really does is it predicts the tolerability of drugs, not the response. There are some studies in progress going on, like right now at the VA, we're doing a study called the PRIME study, where patients are given pharmacogenetic testing at the beginning and another group is not. And the group that is getting the testing will use those outcomes to determine which medications to use. And we're going to see if at the end of the day, people actually do better on if they've been tested ahead of time or if the two groups are even. So stay tuned for that. A little preview of coming attractions. I will talk about ketamine and S-ketamine largely in the psychedelic assisted therapy talk, but these are some interesting compounds that have come into use in recent years. So in summary, depression is a complex and heterogeneous disease without a clear pathophysiology, which makes it very difficult to treat. But we can take a systematic, sequential approach to treating depression and often improve our outcomes. STAR-D definitely showed us that. But I really want to make it clear that even though this may become harder and harder to treat as it goes on, we never want to abandon our patients. Your medication may fail your patient, but you shouldn't fail your patient. You should stick with your patients, even if the thing that you're doing for them isn't helping them. You can have honest conversations about it, that we've tried a lot of things and they don't seem to be working very well. How should we proceed? How would you like to proceed? But you never want to say, well, I've done everything I can, you should go, because that is a kind of abandonment which can be very harmful. Thank you for your attention, and I'll see you in the next module.